Sonia Michelle, and I'm Director of United States Studies at the Woodrow Wilson Center. And I'd like to welcome you to this Wilson Center on the Hill event, Immigration's Hidden Challenge, Who's Going to Care for the Baby Boomers? Before I tell you a little bit about the Wilson Center and then about today's program, let me just remind you that the next program in this series will be on April 19th, which is Monday. I'm not sure if it's in this room, and it'll be on early childhood development in the U.S. and in comparative perspective, looking at Head Start, Head Start as a program in the U.S. and how important it's been in different parts of Europe, and we have a number of different speakers who have been working on that from different angles. So please put that on your calendar and think about joining us on April 19th. Also on your on the tables, you see these cards, and on the back of them are things to check off for mailings that you'd be interested in receiving, publications that we have on offer, and so forth. Fill them out and give them to one of the staff people who are standing around before you leave today, and we'll make sure to keep you on our list. The Wilson Center, as many of you know, is a living memorial to President Woodrow Wilson, and in keeping with the spirit and tenor of his life, its aim is to bring together policymakers and scholars to address key issues in various kinds of policy. And my program is dedicated to U.S. policy, and in particular to examining the place of the U.S. in the world. And the issue that we're going to discuss today falls squarely into that mandate because it touches on both social policy and on immigration. With the baby boom generation on the cusp of retirement, the challenge of providing care for our elders looms large on the social policy horizon. The good news is that Americans are living longer and healthier than ever, but at some point in their lives, all of these people in this very large generation are going to need care of some kind, whether at home, in a long-term care facility, or in a hospital, and the question is who's going to provide that care. Some of the care they will be professional, must come from trained nurses and other professional healthcare providers, but there is and has been for some time a shortage of registered nurses, and with the passage of healthcare reform, that demand is likely to become even greater. Some care can be delivered by people with little or no training, but here too there's a problem. Right now, much of that kind of work is done by family members, especially by women, and as you know, more and more women are working outside the home and therefore are less available to provide care as they once were. So families are increasingly turning to either in-home employees, adult daycare programs, or long-term care facilities to fill the gap. And here's where immigration comes in. Many of the people who provide health care to elderly Americans, whether in their own homes or in formal services or facilities, are foreign-born, and they are likely to remain so for the foreseeable future. What are the implications of this demand for our immigration system? Are the right people, the people we need to provide these services, being allowed to enter the country? If not, why not? And what reforms might be needed? Or should we be thinking in a different direction, finding ways to create a homegrown workforce of care providers so we won't have to rely so heavily on immigrants? These are some of the questions that today's panelists will address. As you can see from their bios, and I hope you've all picked them up or you can get them on the way out, our speakers bring a wide range of expertise to these issues. B. Lindsay Lowell and Elzbieta Gojak are Director of Policy Studies and Director of Research, respectively, at the Institute for the Study of International Migration at Georgetown University. And they've just completed the U.S. component of a large comparative study on the role of migrant care workers in aging societies. This is the report that they've prepared, and I think copies of it are available online or outside.
I brought a few copies, and then they're available online.
They're available online, too. And so Lindsay and Elzbieta will focus on the demand for elder care and the composition of the elder care workforce and specific problems that are inherent in that relationship. Mary Giovanoli, to my left, is Director of the Immigration Policy Center, which is part of the American Immigration Council. And she will place the current demand for care workers within the broader context of current immigration policy and consider prospects for reform. Finally, Bruce Morrison, who is chairman of the Morrison Public Affairs Group, as a congressman, played a central role in the passage of the 1990 Immigration Reform Act, which is the policy regime that we're living under at the moment, and he's going to present his vision of the kinds of reforms needed today, needed now to reconcile immigration policy and care work policy. So each of our panelists will go in this order, and each of our panelists will have about 10 minutes, and then we'll open the floor for questions. Thank you very much for coming, and thank you very much for our panelists to being here today.
Good afternoon, and I'm happy to be here, and thanks to the Wilson Center for having us. I am going to report a little bit today. I've got 10 minutes, so I'm going to go very quickly. I'm going to talk about some of the background and context of the long-term care industry, and specifically about the foreign-born labor force. I'll roll out with some of the conclusions or takeaways we took from our study, and then I'm going to hand it over to my colleague, Elżbieta Wojciak, to talk about some of the field work that she conducted. Why is my institute interested in this subject? Well, because today there's about 5 people of working age for every elderly person. Within 2 decades, there's only going to be about 3 people of the working ages for every one elderly person 65 and over. Now, where we're going in terms of the future demand for elder care is an open debate. You may have seen this morning that a recent study found a 25% reduction in heart attacks among elderly people in the United States. So people are living longer, they're living better, but there's going to be a lot more of them, and it's clear that there's going to be an increasing demand. In fact, the Institutes of Medicine just recently came out with a report based on a commission that argues that tomorrow's labor force in long-term care is inadequate on many fronts. At the same time, they didn't address the role of the foreign-born, and that's what we're doing. Our report today is part of a project that involved Ireland, the United Kingdom, and Canada, so 4 countries. And amazingly, as different as they are in many respects, there's a lot of overarching similarities in terms of the role that the foreign-born play in long-term care in these aging societies. The long-term elder care context in the United States is one in which the funds are about 2/3 coming from Medicaid and Medicare. The rest is out of pocket. Even here, the scene is changing rapidly with President Obama considering certain kinds of tax reprieves and a lot of insurance now being provided for long-term care. The other thing that's important, though, is home care is moving that elder care is increasingly moving into the home care settings. And there are a number of home care settings. That's important because that's where migrants, as we'll see, really predominate. So the funding sources are moving specifically into the areas in which the foreign-born work. There's estimated to be perhaps 38 million caregivers in the United States today of all stripes. That's a large labor force, but it's mostly family and friends. We're interested primarily in what we estimate to be roughly 3 million long-term care workers divided into 2 basic segments of labor. One are professional care workers, that'd be physicians, nurses, and therapists, and the other would be what we call direct care providers, the front line of home care aides, nursing, and home health aides. Well, professional care workers are about 20% of the long-term care labor force. Direct care providers are about 80%. So the story is, in many respects, primarily about direct care providers whose average education is just about high school. In terms of professional care labor force, about 15% is foreign-born. That's about the same percentage as immigrants' presence in the overall U.S. labor force, about 15%. So the immigrants are not overly overrepresented, say, among nurses. And nurses, in this context, are RNs, registered nurses, but also LPNs. And especially in long-term care, the story is quite a bit about LPNs, especially in intermediate kinds of care settings. Our estimates also suggest that only about 3% of the professional care labor force is unauthorized. Among direct care providers, about a fifth, a little bit more, about 21% are foreign-born. So clearly, immigrants are overrepresented among direct care providers. Yet only about a fifth, or about a fifth, of direct care providers are estimated to be unauthorized labor. So there's clear differences between the 2 sectors. Now that's an issue of concentration in the workforce overall. I want to talk about double concentration of immigrants in long-term care by sector and place. In terms of sector, a little over a quarter, approaching 30% of all the workforce in home care settings, home health care services, individual family services, and private households are foreign-born workers. Well over a third of the labor force in private households is foreign-born. So clearly there's a sectorial concentration in these lower-cost care settings. In terms of place, there's a triple concentration by metropolitan area. About two-thirds of the foreign-born are working in this workforce in just about 24 metropolitan areas. In those metropolitan areas, the foreign-born can make up between two-thirds and three-quarters of the entire direct care workforce. So when you boil it down to just metropolitan areas, you can see that the foreign-born are really playing a very significant role in delivering care to the elderly of the United States. And that concentration, in terms of the triple concentration by metropolitan area, really is found in the central cities of our metropolitan areas today. Where do the migrants come from? In the United States, in terms of the direct care workforce, about 6/10 come from the Western Hemisphere. Clearly, a lot of them from the Caribbean, the balance coming from Mexico and Central America. Only about 20% of direct care workers come from Asia. And while I said that about 20% of this labor force is unauthorized, that's less than the percentage that you see in the labor force overall. To put it shortly, about 4% of all direct care workers are unauthorized, compared to about 5% of all workers in the United States. Among the professional care labor force, it's quite different. Unsurprisingly, about 4/10 come from Asia, and particularly the Philippines, right? Especially in the nursing positions and even the LPN positions. Yet another quarter come from the Caribbean, particularly Jamaica, with only about 7% coming from Mexico and Central America. So these workforces come from very different kinds of places. When you're talking about the direct care labor force and thinking about immigration policy, let's remember that most of these direct care workers have no means of entry under the U.S. admission system. In fact, what we find overwhelmingly is that they appear to come through the family-based classes of admission as well as refugee classes of admission. Some obviously come through unauthorized channels. In the professional care labor force, it's quite different. In fact, the field research seems to suggest that most are coming through the employment-based classes of admission. Some clearly are coming through the H-1B. Numerically, they must be. But one also suspects, as we saw in the field, that some direct care workers are using their experience there to gain time and money to go on and pursue education that gets them an LPN or an RN. So some are coming through family categories as well, although the breakdowns are unclear. In fact, a lack of knowledge is mostly what you can get by looking online to see what the U.S. government collects in terms of where immigrants workers are coming. There's very little that we know. A couple of final points then. One, we also, of course, looked at the labor force characteristics of these workers. And what we found that overall is that the foreign-born actually earn slightly better than the native-born in this sector. At the same time, when we interviewed online well over 500 employers, non-random survey, but a large sample, we found that they found it difficult to recruit natives. In fact, 70% reported a shortage of natives with the right skills. But follow that up immediately with the fact that about 60% said that natives were hard to hire because they could earn higher wages elsewhere. Furthermore, about 50% of employers reported that natives demand higher wages than the foreign-born. At the same time, when we asked them about the foreign-born, only about 13% of employers said that they were willing to work for less than natives. How do we put this all together? First off, it doesn't seem to be the case that there's widespread discrimination against immigrants in long-term care. If anything, there's a slight preference for long-term care workers for reasons we can't really discuss now. At the same time, it's a low-wage sector. One of the biggest problems employers see in terms of hiring natives, in fact, is that they can't pay enough to attract them. This is a general kind of conclusion about the workforce. We can't break it down by any one particular occupation, but it would clearly characterize in particular direct care workers and home care sectors. That would seem to be most obvious. In fact, that's what the empirical data also show. What do we conclude then? Clearly, future demand is going to increase, but we already see a large presence of the foreign-born in providing long-term care in the United States, and in fact, in Ireland, Canada, and the United Kingdom as well. What do we recommend? Our takeaway from this is that the problems in this sector in terms of access to labor and in terms of the skills that might be needed or in shortage is that there are sectoral problems. This is indeed, in fact, what the Institutes of Medicine kind of concluded, that if we want to change the workforce outcomes in the sector, the primary lever we have to push is how we deliver and fund health care in this sector. So we should prioritize professionalization and certification of direct care workers, among others, and increases in funding for nurse training should be a high priority. My colleague will talk a little bit about the adoption of voluntary codes for recruiters in this industry, which is an interesting growth area in terms of the professional workforce. In terms of the immigrants, we also encourage government support for language and other training through direct funding or tax breaks. We also saw some problems with cultural sensitivity in this sector, which would be a useful thing to explore both for migrants and employers. Finally, in terms of the U.S. immigration system, our focus specifically on the direct care workers leads us to see that the current classes of admission are clearly bringing in quite a few. It's also difficult to devise targeted visas for low-skilled workers. However, it's clear that legal admission should be reformed to improve access for professional workers and possibly even for direct care workers if evidence of shortages are convincingly shown in that sector. Any creation of health care visas should be coupled with funding improvements for domestic educational institutions. And that, I'll put it over to Alvietta.
Thank you, Lindsay. Thank you to the Wilson Center and to Sonia for inviting me. It's a pleasure to be here. Let me give you a little snippet from the bottom up, what we did in terms of empirical research on the ground. Lindsay already alluded to the large online survey, but in addition to the online survey, we actually did a bit of what, from my professional vantage point, I would call crude ethnographic research in two localities, in Arizona, mainly in Tucson and Phoenix, and then in the Washington-Baltimore metropolitan area. And we had interviewed about 50 care workers at all different levels of skills, coming from very far-flung countries such as Mongolia, Taiwan, China, India, Kuwait, UK, Russia, Eritrea, Ethiopia, Nigeria, Vietnam, Burma, Finland, Sudan, and Mexico. So you see the United Nations kind of spread. We also talked to recruiters and employers in both of these localities. While the statistics suggest that since the 1990s, there has been a tenfold increase in recruitment agencies and hiring from abroad in this field, in the long-term care workers. In the field work, we actually found out that very few nurses, and I'll be making a distinction between nurses at all levels of skills and the direct care workers, or what our UK colleagues call the social care workers, that very few nurses were hired from abroad through a third-party recruiter. So not some, shady kind of a place or even a more sophisticated kind of a place, but that the employer would have a recruitment department, whether it was a large hospital or a large healthcare system, and they would perhaps work with a recruiter on the ground to help them screen and deal with logistics and that kind of stuff, but it was the employer that was also the recruiter. On the other hand, as Lindsay already alluded to, none of the direct care workers were recruited or even came with an explicit job motivation in this field. they came mainly as family members of other immigrants or refugees and that kind of stuff. The nurses, on the other hand, were recruited for very specific jobs. And although our notion was to look at nurses in the aging, in the gerontology field, when you think about the localities where we did our research, many employers told me, well, we don't necessarily hire them to work with the elderly, but in Arizona, for sure, sooner or later, they will be working with the elderly. So there was one large employer here in Baltimore who specialized. She's herself a nurse and a gerontological nurse, and she actually went on and on about how little attention is being paid in the nurses' recruitment to recruiting for particular set of skills, not just the nice bedside manners, but broadly defined gerontological skills. All of the nurses that we had interviewed came in with green cards, and therefore could also bring their family members with them. Some of the employers were advising them not to bring the family members immediately, but give themselves about a 6-month period to get integrated into the workforce before they will be dealing with larger integration issues for the family members. It was interesting trend that among the people that we interviewed, a large number went directly from their country of origin to the Gulf states to work in what they refer to as the American hospital, meaning a hospital that used English language to gain further experience in the English language before they would come here. They came to work, as I said, to work in nursing, but not necessarily with the elderly. There were some cultural differences in nursing care. We never really heard about lower quality of nursing, but cultural attitudes towards working on a team with a physician, towards working as a team, to the type of decision making that they were used to or they were not used to, and communication styles. We had interviewed several ethnic-based professional associations of nurses that saw themselves playing a great deal of a role in terms of mediating the differences in communication styles, providing the on-the-job kind of training. I shadowed some of them as they were training in large nursing homes and hospitals and that kind of stuff. The migrant direct care workers, on the other hand, had somewhat different pathways to employment in the United States. And there was even a large difference, significant difference between Arizona and the metro Baltimore, Washington area, because I think somebody already mentioned that in Arizona, you can get paid to take care of your family member who is an elderly. And many of the immigrants took advantage of that law on the books and actually went out to become quite successful entrepreneurs. I interviewed one Russian nurse who practiced nursing in New York City for many years, then moved to Arizona and opened a business. And at the time of the interview, she had 74 different employees, not just Russian speakers, but from all over the place. So it was an interesting thing. In Washington, D.C. proper, when we asked the question, is there a shortage of direct care workers? Do you have to go to ethnic communities and recruit migrants? The resounding answer was no. We don't really look for migrants specifically. We have migrants in our workforce on a walk-in kind of a basis, but we work mainly with the welfare to work type of programs that cater primarily to African American women. And this is a wonderful partnership. We can get the graduates out of these programs and then put them to work immediately. On the other hand, just across the river in Northern Virginia, the picture was drastically different, where employers in larger nursing homes said, well, without the refugees and the immigrants, we would not be able to run this place. Because this is also a diverse area, an immigrant and refugee area, we also heard about programs specializing in recruiting direct care workers for particular ethnic communities. So I interviewed a Vietnamese recruiter who was working with a larger program catering to a wider variety of elderly people, but he was recruiting within the Vietnamese-speaking communities to work with Vietnamese-speaking elderly. The employers really provided a almost unrealistically glowing picture of the migrant workforce. I joke that, you know, in no workforce you can find such perfect people only, but we're very, very pleased with the work ethic, with the communication was a problem, but it wasn't nearly as much English language as differences in communicating, and they attributed a lot of the communication difficulties to the old age of the patient that they cared for, not necessarily to anybody's linguistic abilities or lack of such. But the ethnic community-based professional organizations were saying that they were training also in the sort of enhancement of the English language on the job type of a situation. So I think that's about you know, the sort of snippet of who we talked to and what we heard. You can ask me further questions about particular case studies later on. Thank you.
Well, I hope you all are deserving or enjoying a much-deserved break, and I'm grateful that you came here to talk about immigration-related issues, although this is obviously much broader than that. But what I want to do is try to contextualize the study a little bit into sort of some concrete information that I think you can use in talking to your members, to staff, to constituents about the importance of immigration reform today. So I run the Immigration Policy Center, and that's sort of what we do on a day-to-day basis, is try to translate a lot of the terrific work being done in academic circles into kind of concrete, usable information and package it up for folks in ways that help kind of put the dots together. So I think you have to start from the premise, or at least allow me to start from the premise, that we have a system that really doesn't work very well anymore in most respects. Bruce, as an architect of the 1990 Immigration Reform Act, I think will agree that, you know, it used to be the case that we would reform and update the immigration system on a more periodic basis to reflect various changes in the development of our culture and society and such. But we really haven't done that on a systematic basis for a very long time, and consequently it's created a number of pressure points within the system. You've probably heard talk about a lot of them recently, particularly with Senator Schumer and Graham's introduction of a three-legged stool, four-legged pillar. You know, the number of components changes all the time. But basically, when you're looking at immigration reform, you've got to talk about issues relating to enforcement, so border and interior security and enforcement issues. You have to talk about addressing the issue of 12 million folks who are here as undocumented workers. You have to talk about what's going on in the future in terms of how we regulate future immigration flow, which is some of what this report touches on. And you have to talk about the family and employment means that we have for getting people into the system right now, the legal immigration process. And I think this report actually provides some really valuable information about that legal immigration process that can help direct thinking on what should be the right approach in dealing with these concerns. And here are a couple of the things that come to mind as I read the report. First of all, one of the problems that we have right now with our legal immigration system, which is family-based and employment-based, is that we have tremendous backlogs. The overall demand exceeds the number of visas that are available every year for people to come into the country. And what that does is start to create bottlenecks and delay people being able to bring in their family members, delay workers or employers being able to bring needed workers. And you see that push-pull both in terms of high-tech or higher skilled jobs where there's an increasing demand for, say, nurses that I think Bruce is going to specifically address that can't necessarily be met. But you also see it at that lower skilled level. And one of the things that I think this report does extremely well is help us to sort of understand how bringing people into the system who aren't in the sort of traditional high-skilled, high-tech, people with master's degrees or PhDs, how having people coming into the country legally who don't have those, sort of letters behind their name, nonetheless is critically important to the growth of our economy and our ability to function as a society. So I thought it was fascinating that they found that there was not only a higher percentage of the foreign-born in the direct care work, so the cleaning and the bathing and the feeding and the accompanying people, things like that, but that it was largely a pool of foreign-born people from family or refugee based admissions processes, which means that a lot of those folks who come in as brothers and sisters or adult children or who come in through the family system are probably the people who are caring for the elders in our nursing homes and other facilities. And that's really critical because one of the major debates that you're going to find yourselves confronting is the debate about how do we balance future flow between employment and family. And there are a number of people who argue that we need to scale back family numbers significantly and increase employment numbers to sort of go after the best and the brightest, to make it more merit-based. You may have heard talks about point systems and things like that. But it, I think, misses one of the critical points that, as I said, I think is made in this paper, which is that we need a variety of people with a variety of different skills to be able to actually keep our country going and growing. And in fact, in the paper itself, there's actually a point where they sort of talk about you can't really quantify a lot of the skills that the folks who do well and are caring for elder citizens have, because it's that ability to communicate, it's empathy, it's a variety of things that don't really work themselves very well into a point system. And so I think it's really critical that you all have done this research to sort of help explain that it's not our immigration system isn't necessarily all about numbers and points and sort of trying to find some kind of magical key to finding the right people. The second thing that I think is really important in this report is that you actually saw that in this particular market there was competition that seemed to be keeping wages pretty equal. And you all can correct me if I'm wrong, but there's often these misperceptions that immigrant workers tend to bring down wages and things like that. But in a market where there's sort of equal demand, you're seeing fairly equal wages, which suggests something that a lot of our research on the broader idea of comprehensive immigration reform and on unemployment and issues like that has also demonstrated, which is that number one, most of the time, if you're going to try to sort of even out the system and create a system where you're legalizing people and you're really leveling the playing field, it literally does level the playing field. And I think the fact that you have such a higher percentage of legal immigrant workers in this particular, the direct care market, helps to show that in a very specific kind of way, that it actually can be beneficial to workers across the board. The third thing that I think is really, really fascinating about the report is that, as Elisabetta was saying, there's a lot of entrepreneurial spirit that has taken hold in this group of direct care workers. And so again, I think I saw two things. One was that there were a number of folks who may have come into the country with various skills, but when looking for a job, they came to the direct care world in part because of incentives like tuition assistance and other things to help them move up the ladder into more professional and more higher skilled work, which is a very sort of traditional model of self-improvement, and it's one that's been repeated over and over again in the immigrant experience. So you see that, and you see that coupled with the fact that people are starting businesses and showing this entrepreneurial spirit. And you're again getting that sort of underlying message that people who are coming into the market in lower skilled or less skilled jobs are still contributing a great deal and often are in a position to help themselves move up in the process, all of which is sort of integral to continuing to grow the economy. So all of those things, I think, are really critical components of this report because it gives you a window into a world that a lot of times we're just speculating about. I mean, we can track sort of high-skilled numbers and access and demand in ways that it's much more difficult, I think, to track what's going on and what the needs are for lower-skilled workers. So I think this is really an important contribution that they've made. And so I'll end with that, but are happy to continue this discussion in a minute. Thank you very much.
Good afternoon. I want to thank the Wilson Center for inviting me to participate in this discussion. And I want to apologize up front for the fact that I have a conference call with a client at 1 o'clock. So my running out the door is not that I'm afraid of your questions, even though it may appear that. My associate who works with me in our firm, Paul Donnelly, is over there. And if you have questions or you'd like to follow up on anything that I talk about, please talk to Paul. I'll be happy to come to your office and answer any questions that you have, probably at length that you would rather I didn't. I served here as a member in the 1980s, and the first thing I'd like to say about this discussion of demographic trends, it has to do with numbers of people and numbers in the budget, is that nothing seems to change. That we've been projecting these curves that don't come together in the future for a long time, but we don't seem to be able to ever change the shape of the curve, whether it's financial or demographic. And I don't know what that says about us as a country or the Congress as an institution, but somehow or another, these things don't quite work out the way the projections suggest, that there are lots of other forces that change things beside the policy process that is supposed to address them. So whatever predictions you hear about how the world's going to end are probably not true. These important trends to recognize and to respond to, but our ability to predict the future and to change the world is limited. So we ought to think about these problems in discrete terms that we can actually see progress in a reasonable time frame and rather than try to take on the whole picture. When we talk about immigration, there is a tendency to kind of get the dog and the tail confused. This is a country of 300 million people. It's the third most populous country in the world. When we talk about immigration, it's a million people a year or so, depending on how much you count people who come illegally or overstay illegally. Those numbers suggest that if we want to talk about the question of meeting workforce needs, we have to talk first about the population, the people who are already here in the United States, and then talk about how that needs to be affected at the margins by the people who are brought in or who come in. And proposals to focus on immigrants and immigration as the workforce regulator really get it wrong, because they ignore the two big things that need to be going on within our own workforce, which is education and problems of wage levels and conditions that cause people to work in important jobs at wages that are not living wages. Immigration should not be a solution to either of those problems. It may be an interim intervention to deal with them, but it ought not to be the solution. It ought not to maintain low-wage jobs rather than living wage jobs, and it ought not to be a substitute for providing education and skills to people who are already here. And in both those situations, there's always a risk of that going on. And the reason there's such a large risk is twofold. One, we have no agency or program or approach to have a human resources policy for our country. I mean, what is immigration but a piece of a human resources policy for the country and other values that are tied to it? But we don't even discuss this. I mean, there is no place, there is no forum, there is no part of our government that has any kind of coherent overall view of, you know, the most important resource America has, which is its people. And until we get that kind of a focus on this, I think we're going to keep having these discussions about mismatches of skills and needs. How we get there, that's a challenge. When we talk about how immigration interacts with the healthcare space, I've been working at that particular area for about 25 years, so I have a lot of opinions. But over that time, the thing that most often gets ignored is that different skill levels of jobs make a whole lot of difference. In other words, there's a lot of difference between when you're talking about a physician shortage, an RN shortage, an LPN shortage, licensed practical nurse shortage, a shortage of ancillary personnel like physical and occupational therapists, or the kind of what are being called direct care workers, home health aides and certified nursing assistants, the two main categories of people. Those last two categories, those are people who need essentially a high school education or less and some amount of rather short-term training in order to be certified. All the rest of the people need increasing levels of higher education in order to perform those functions. We don't have a shortage in the United States of low-skilled individuals who are not working right now. I mean, I would say that is a real challenge that we need to be careful about not using immigration as a solution to. That doesn't mean immigration has no place, and I certainly completely agree with the point that there are family-based immigration waiting lists where we've made a commitment that people are going to come. The people may have low skills, many of them, who can fill and will fill important jobs in this demographic situation that we face. We ought to look to that first and foremost as a solution to a gap in low skilled rather than creating categories to continue the process of bringing people at low skill levels and ignoring people who are already here at low skill levels who need to have their skills enhanced or their employability enhanced in order to participate in our economy. Because we have 10% unemployment, nominal unemployment right now. That's the insured unemployment rate. The real unemployment rate's a lot higher. And there are a lot of people in that population that could be doing some of these jobs. So we should worry about that. To the extent we bring people for participation permanently in our economy, we shouldn't have temporary worker programs. Temporary worker programs are exploitive by their nature. They create a mismatch between the expectation of the immigrant and others who are setting the policy. They lead to illegal status, and they are wrong. And they are very convenient because they are a political way to say, oh, these numbers don't count. These people really aren't here. But the difference between a permanent immigration opportunity and temporary worker programs is that temporary worker programs, and I mean temporary worker programs to fill permanent jobs, those temporary worker programs are a statement that we really want your labor, we don't want you. We don't want your family, we don't want your permanent. It's like, a machine tool. We need you 8 hours a day. After that, we don't know you. And there's a great temptation to avoid the political decision to bring people permanently. But if you're going to fill permanent jobs with people from abroad, they ought to come as green cards, not guest workers. And so I think that's an important principle as we do this. And obviously, we don't want an illegal workforce. We don't want a workforce that can be exploited and that is not been permitted to come. And we're going to have to solve the problem of having created a very large workforce of people who entered illegally or overstayed illegally. But we oughtn't to solve the problem by continuing it. We need to solve it by ending it and having an appropriate structure to deal with the problem. Some specific things about nurses. and doctors, the high-skilled individuals. That, first of all, we have an MD system in this country where 25% of the trainees every year in residency programs are foreign-born. The entire system is built upon that. We don't have enough slots in our medical schools, and for the hospitals to operate, they have to get that 25% flow every year. So we are creating that demand because we're not expanding our nursing schools, our medical schools, to allow Americans who want to become physicians to become physicians. And that's where to look for the solution to the problem down the road. It's not constantly looking to bring more physicians from abroad. With respect to nurses, once again, in the long run, a country of 300 million people ought not to have to import nurses. Doesn't make any sense. And yet there is a demand to import nurses. Both the organizations that I represent in this area, which are the American Hospital Association and AMN Healthcare, which is the largest employer of foreign-trained nurses and the largest staffing company in the healthcare field in the country, both of their view is we do not want immigrant nurses or doctors. We want nurses and doctors who are qualified to do the work, and we are forced to this immigration solution by the failure of the society to address the supply needs within our own population. And that needs to go on. So in response to this problem that we don't have enough nurses right now, but that we ought to have enough trained nurses within our own population, we've been supportive of legislation that was initially drafted in the House by Congressman Wexler before he left, and now is being, the lead sponsor is now Congressman Polis, has been very supportive in the subcommittee and in the committee with Congresswoman Lofgren working with us on it. And it has been to balance these two ideas. One, to admit nurses in a limited but significant number over a period of years, but to have the employers of those nurses pay a training fee going directly to nursing schools to expand access for Americans to become nurses. And I think that kind of a model belongs in other areas as well, because where there's a training gap, there is a time gap. It takes time to create a physician or to create a nurse. And somewhere the resources need to come from, and it's not only from this source, but the resources have to come from to increase the training pool. And if we're going to do that, then it would be appropriate to tax the process of bringing people from abroad. So there are solutions to these things, but they're difficult, and I think we'll get more of them if we focus on them in an incremental and focused way on the particular problems and particular ways of solving them. That bill is H.R. 2536. If any of you are interested, we're happy to come and brief you about it. But there are solutions to these problems, but they're hard work. And as everybody up here knows, immigration legislation has turned into the hardest thing to do in Congress, which oughtn't to be the case because it wasn't always that way. Thank you.
Congressman, you have to leave right away, or maybe some people have.
Well, I've got like
2 minutes.
2 minutes.
Do you all want to have to?
Well,
Mary?
but
Yeah. Do you want to respond, Mary? Did you have some?
No, I think that Bruce makes a lot of excellent points. I don't think it's an either or, and I think that we would both agree on that, there's a complement. These things are complementary. And, saying that we need a better and improved immigration system doesn't mean that you also don't think that we need to up the quality of the training that's available to folks here. The interesting thing, though, is that the Immigration Policy Center website, www.immigrationpolicy.org, I think it's probably somewhere on the information, we actually did a sheet that sort of looks at the projected shortages, and there are several fairly significant studies that say even if we increase the training and produce more doctors and nurses, in-house, so to speak, we're still going to have a gap that isn't necessarily all closed. And so it's a dynamic kind of thing. And one of the problems I think that we have with immigration really is that it's very difficult to project out what we're going to need 20 years from now, which is when a lot of these new gaps or problems might occur. So it's got to be a process that works together.
David?
I'm David Klaus with the Wilson Center on the Hill program. Quick question for Congressman Morrison before he goes. Are these the types of things that have to move as an omnibus immigration bill, or are we going to start seeing the process move with separate pieces of things? I know that everyone senses there's a huge log jam over omnibus immigration reform. What's your thoughts on how this process goes?
Well, I'm supportive of a comprehensive bill if it can be achieved. I'm not, but I don't think a comprehensive bill is the only way to solve these various problems. I think they can become at in pieces. Now, some people have decided as a policy matter, as a political matter, to tie everything together and it's all or nothing. I don't have to agree with that, but there are some things that inevitably have to go together. And what has to go together is you can't do a legalization program, which is absolutely necessary in order to solve the problem of a system that hasn't worked and that has millions of people who are here who aren't leaving, and we aren't getting rid of them, and they're totally integrated into our economy and our communities. We have to have a legalization program. And to have a legalization program, we have to convince the American people that we've shut the back door for the future. Those two things cannot be separated politically or substantively. So they have to go together. Some people would say you have to solve all or most future flow problems before you can do that. I'm more skeptical about whether you have to solve that problem, because I think that problem gets a lot easier when you solve the first one. But you can't do legalization until you close the back door, and that clearly, those legs of the stool, however you want to define them, as enforcement or compliance in the work site, those things have to come together with the legalization program. And I think if Americans believe the back door is really being closed, they'll be supportive of legalization.
Lindsay and Elzbieta, do you have some comments you want to make just now? Yeah, and then we'll open it up.
I think we'll
Open for questions.
Okay, questions, comments? Please wait for the microphone, and also please identify yourself. Thank you very much for being with us. Questions, comments? Yeah.
Hi, I'm Chris Wilson. I'm an intern at the Wilson Center and also a master's student at American University. I was just curious if anybody here, we had somebody leave that might know the political side better than others, but where the AARP is on this, if they're, seems like an issue, they're a powerful political force, this might be an issue they're interested in. What do they have to say?
I don't have a thumb on this.
The AARP is, like a lot of large organizations, very bureaucratic, and this has been an issue that they've really been unwilling to tackle sort of systemically. One of the few points where on immigration generally that we saw the AARP speak out was in 2008, when there were estimates that a proposal introduced by Heath Schuler and Tom Tancredo called the SAVE Act, and a number of other co-sponsors were on it too, would cost the Social Security Administration a ridiculous amount of money. The AARP came out saying that they didn't support the bill, and that was, for folks who work in immigration, a pretty major breakthrough in terms of communicating about these things. I think it's an area where there's a lot more hopefully to come, but they're such a big organization, it takes a while to work your way through their process.
Hi, thanks for talking. Luke Murray, Representative TED Post Office. Thank you for all of your presentations, very thought-provoking. One question I had, it seems like the majority of workers who help the elderly who are actually immigrants are more in the direct care, is that right, as opposed to the nurses and the doctors? So, and it's also my understanding that the direct care requires a significant less amount of education, not much more than a high school education, if that. So I'm a little confused about why there's this focus on a lack of education, a lack of training native workers if you really don't need that much education for direct care in the first place. And then the second question is I wonder if anybody can bring a historical perspective to this issue. It seems like the history of our country, we see waves of immigrants come because there's financial opportunities, because there's job opportunities, and is it so bad that this is just the latest job opportunity for workers, and do we really want to think about stemming off immigration for long term as we try and predict future ways and future needs when our country's made up of immigrants? So if you could tackle those two questions, that'd be helpful.
Yeah, again, I mean, it's like most things, keep on peeling the onion. The direct care and the professional care labor force are really different. There's at least two major occupational groups in direct care, home care, and then I think Bruce was calling them certified
LPNs.
No. CNAs, but there's also nursing aides. I mean, there's a range of occupational definitions, but basically, those jobs are basically usually little less than a high school education. Okay, but then there's additional training beyond that, and even that comes in tranches, again, depending on which sector you're working in, who's paying you, and those kinds of things. But usually minimum 72 hours of training for some of these CRN kind of positions. But again, it varies quite a bit. The professional care, again, has tranches, too. It has the LPNs, and there's different kinds of LPNs. There's RNs. There's different kinds of RNs. RNs, as you know, can be typically a bachelor's degree, but not always. And some RNs have PhDs. So there's a real range of educational qualification at the professional. And of course, professionals in this sense also include physicians. So there's a big range. Right. In terms of direct care, what the Institutes of Medicine has been arguing, and some of which already accompanies government Medicare kinds of payments, is requirements for additional training in the direct care labor force. And there's really, again, a big range of, it kind of boils down in a simplistic sense to how much medical care you actually provide. If you're just there for assisting in daily living, helping somebody get in and out of bed, clearly the training requirements are a lot less than if you're giving medications, if you're observing for certain kinds of things. So there are different levels. But most people in this field, and certainly Institutes of Medicine has called for, and we agree, that training is all to the better because it's going to provide a better quality of care for the elderly and hopefully command higher wages for the workers as well. So that, I hope that answers your question a little bit. So you get,
So are you saying then that training is a significant hurdle to enter this workforce?
no, it's not. It's not a significant hurdle, nor do I think actually that the additional training the Institutes of Medicine and others are calling for would be a significant hurdle in terms of the educational needs for these workers. The issue, of course, is like everything, is funding, right? People have more training. It takes time to get the training. You have to fund the training. How does it take place? So it becomes much more problematic.
Isn't part of your argument, though, that if there's additional training, the working conditions will improve, the wages will improve, them, maybe it will attract more of a domestic labor force? Is that part?
Yeah, absolutely. Yeah, sure.
Yeah.
But also, it's the desire to go into a particular line of work. I held several focus group discussions in sort of nursing homes where the workforce was very diverse, composed both of U.S.-born people and immigrants. And many of at different levels of skills, many of the U.S.-born workers were saying, well, and I am advising my children not to go into this line of work because it is a very difficult line of work, while the migrant workers were saying, well, I'm actually advising my children to follow in my footsteps because increasingly many of these institutions will provide tuition incentives. So this is not a dead-end job. I'm not going to stay here, in that kind of work forever. Many of the women that I talked to were already in nursing programs while working, while working full time. You also have in each of these kind of situations people working, several jobs. So they might be working in an institutional type of care where there's more training required, but then working for helping with the daily life kind of thing in the home. And the home part would always be discussed as this is the least desirable kind of a situation because not only it pays the least, but it's the most prone for abuse for the worker, and that kind of no regulation, that kind of stuff.
Mary, do you want to address the historical dimension?
I mean, I think you sort of hit the nail on the head. There's sort of an ebb and flow of the immigrant workforce, so that by the time, you hit third generation folks, let me give you an example. Lots of times when people are looking at the changes, from first generation to second generation to third generation, some of the opponents of immigration generally will talk about things like language, and people don't want to speak English, or they don't work the same kinds of jobs and things like that. And when you actually look at the statistics and the numbers, what you see is a very sort of the rags to riches pattern repeated over and over again, regardless of what ethnicity it is. People come in, they work hard, they hold down lots of extra jobs to give their kids opportunities they didn't have, and so then those kids are often, have English acquisition and graduate from college and do all the kinds of things that you would expect anyone to at least try to have the opportunity to do. So I don't think the point really here is that you're trying to change that pattern or make it more difficult for immigrants to come in and do those kinds of jobs. If anything, what we've seen in the political landscape is that many people have tried to argue that you need to focus immigration only on the high-skilled workers. In part, this argument is that, we have, to sort of put it kind of awkwardly, but we have plenty of people who are, only have high school degrees who are going to want to do these jobs. But the fact is, actually, the percentage of U.S.-born workers who only have high school degrees is smaller and smaller all the time. And like most people, there are reasons why you want to move up and out and do different things and use different parts of your skills. So I think that what Lindsay and Elisabetta were both saying was that even in this workforce, you're seeing that same desire repeated over and over again to, use this maybe as an entry-level job or to fulfill certain desires or needs, but that it also can be a stepping stone to other things for yourself or for your family. So, I think one of the big concerns we have is that there's a real movement to try to cut off lower-skilled immigration for fear that that we're taking jobs away from Americans, but in fact, it doesn't work out that way when you look at all of the data.
I'll get to you in a minute. I just want to add, if I may, something. I think another historical factor, something that's different, is that American women have moved into the labor force more than before. So the kind of work that immigrants are doing now, that migrants are doing in terms of elder care, is work that women would have done in their own families in the past. Child care, elder care. So there's much more of a demand for care workers because women are not doing that. It's unpaid labor in their own family. They're moving into the paid labor force and they're hiring other people to take their places in the home. So that's a big switch. The other thing is that earlier, I think you would probably agree with me, first of all, immigrants, it was male immigrants who came a lot before. Now women are migrating much more worldwide by themselves or with their families, but often they're leaving their families at home. But the migration of women by themselves is much, even married women, is a relatively new phenomenon. And also, when migrants used to come here, they came to build our roads, to build our, to dig ditches, to work in factories, to work in the mines, and so forth. And they're not doing that anymore. Instead, it's care work that they're doing. They're either doing high-tech work or care work. So those two sectors, I think, are more important than before. Yeah.
My name is Olga Gulina, Potsdam Institute, Germany, and I'm Canon short-term scholar of the Canon Institute. I have one question to Mr. Lindsay Lowell. I'm really impressed with what you told, that 21% of immigrants-born workers earn more money than natural citizen of United States. The last report of Germany shows that the citizen of Germany with immigration roots, the second generation, who fluently speak German, have a perfect education, but they must apply 8 times more than another person who have German background, and in the same way they earn 10 times less than another people who has the same background. In this case, I have a question. Does America automatically recognize it, the basis education which these people, migrants, earn in foreign country? How it's happened that they come here, it's clear that they come with a green card, that they have educational training, but how America recognizes their basis education? how it's happened? Do you have a special program?
I think there's a number of questions bundled
Yeah,
up in
it's
there.
a lot of, yeah, I know.
In the first place, what our research with U.S. survey data seems to indicate is that across all occupations in the long-term care industry, it's a use of occupation industry codes to get there, migrants earn a little bit more than natives, and they do that even in a regression format where you control for the number of hours worked, and interestingly enough, their education as well. This is pretty, I think, unique to the long-term care sector. When you look outside of the sector, the other area will look a lot of work in science and engineering. You find that scientists and engineers are better educated, foreign-born, or better educated than natives by and large. And so when you control for education, they earn less than U.S.-born scientists and engineers. So this sector is a little bit unique, and we're not really sure what's going on. The field work did find that employers said they like foreign-born workers because they show more dedication. They have a cultural affinity for working with the elderly. When you hear those kind of things from employers, you usually take it with a grain of salt, right? It means they're willing to work harder for less wage, but that's not what we're seeing here. And so we don't really know. I'm working with some data from nursing homes that suggests that one of the things we're seeing is consistent with what employers said when you use survey data, which is that in nursing homes, the immigrants seem to stay with the same employer for longer periods of time.
Yeah, but when you apply for this position, you must submit your CV, and then you must show that you have some medical background with some educational certificate.
Well,
Germany, in case of Germany, they always prove it.
Well,
say that it's not the same.
okay, well, again, you'd have to take that almost occupation by occupation to answer your question, because in the United States, home care aides basically don't have a lot of educational requirements. You're talking about nursing aides, then some of the certification requirements are greater. They're getting those and earning those in the United States, just like the native-born components counterparts are. If you're talking about LPNs and RNs, if they're educated abroad in the Philippines, they're being trained to U.S. standards, and they're passing certification requirements when they get here. Same thing with physicians.
Well, on the nurses' side, it takes on average about 2 to 3 years for a nurse to come and work in the United States, and part of it is not just dealing with the immigration paperwork, but it is to pass the NCLEX exam. And there is a high deal of quality control of how well people do on these exams. And the other piece, when I ask the employers, why are you more and more playing the role of the recruiter, that issue of comparability of education and then wages came up, because people were saying, I do not want to have a workforce that is thinks that the other is less educated and thinks that the other makes more money. I want to have an even playing field. So they come in after having passed the same kind of exam. Many more, increasingly more foreign schools train on American textbooks and train in English. So the education is very much the same. But you probably couldn't say that about many other disciplines and many other industries.
Or many other countries.
Right.
Mary, do you want to comment on that about different other occupational sectors?
No, the only thing that I wanted to point out was that in your paper, you mentioned both sort of length of time on the job and the fact that that folks were often older when they came into the workforce as, I think, interesting things. And we did a series of papers looking at the unemployment rate and the role of immigrant competition for various jobs. And one of the things that you found was that when there were big imbalances, it was often based on issues like this, that there might be more U.S. citizens who were unemployed in a particular area, but they tended to have less than a high school degree or just a high school degree, and they tended to be younger, whereas the immigrants in that same urban area would tend to be a little bit older, would tend to have their high school degree, things like that. So it's really difficult when you're looking at any issues relating to immigration and employment to sort of treat it as apple for apple, or as one of my colleagues says, people and the jobs, when you're looking at them, they're not interchangeable like batteries. You know, you really have to think about all of the different things that are going into doing that analysis, and I thought your report sort of teased out some of that in interesting ways.
More questions? Well, I just have one question myself. In the report also, you mentioned that there seem to be concentrations of migrant workers in elder care in certain places in the country. I wonder if you could just talk about that a little bit.
Yeah, migrants, generally speaking, often concentrate. They're in fewer metropolitan areas and a subset of states, and you certainly see that with this population as well. Somewhat surprising to me was that about a quarter of the foreign-born in long-term care work are found in New York City alone. And that's kind of strange. We don't know why that's the case. I can only speculate. It was, they had a large out-migration in the 1990s. One of the things that New York is known for is its high incidence of NORCs, or naturally occurring retirement communities. What are those? Those are people who live, people who live in age in place. They stay in the apartment buildings, the condominiums, and the homes that they've lived in all their lives. And I think maybe what happened in New York is a lot of the children left, and the older folks were left, and the migrants took over the jobs of formal care. That's the only thing that makes sense to me. Plus, there's a large concentration of immigrants in New York. And the other thing that's unique about New York is its concentration in the central city, especially residential kinds of phenomena, which is, other cities, the central city's not always exactly what you think it is. So that's something else that goes on. So there is this regional concentration, this metropolitan concentration. Among other things, that brings up in the immigration issue this whole issue of underserved areas. We do have visas for migrant healthcare workers to go to underserved, primarily rural areas. There's been problems with that in the recent past, with the J visa and whatnot. And this kind of tells you that, you have this kind of strange bifurcation where most migrants are actually concentrating not only in a few cities but in the central cities, but we've got a visa system that's actually hoping to attract them to the more rural areas where natives often are even more scarce, oddly enough.
I wonder if the fact that they're I'm thinking about this issue of how migrants tend to make slightly more than native-born workers in this field. I wonder if the networks because of the concentration in places like New York, there are networks that people say, hey, you could want a job. First of all, I'm going to help you get a job. And second, this is the wage you should be asking for. So that would drive up the wages a little bit. Do you think maybe, Elsbeth, you came across that in your anecdotal?
Well, on the nurses' side, everything is standardized and uniform, and there's a pay scale. The only difference in pay was between the few people that were not recruited directly by the employers, but recruited by the third-party kind of recruiters. So they usually had 2-year contracts, and whatever they were able to negotiate. And perhaps they knew what the prevailing wage was, perhaps they didn't. So that was the only difference. In the direct care work, it depended. It really was all over the map, because many people would work for a nursing home, command one type of a wage, and then, in the evening work for somebody privately in the home and commanded a totally different wage for that, through networks, through, whatnots. But I also looked at some programs here in this area where a woman who has been working for 2 programs as a sort of freelance caregiver for about 10 years, her per hour salary increased by something like 30 cents in those 10 years. So, no upward mobility of any sort. So it was all over the map.
Mary, some final thoughts?
I'm really glad that you all came to listen to what is a very complicated but I think important issue about how our immigration decisions really affect every aspect of our country.
Well, thank you very much to our panelists for bringing us such informed and interesting presentations. And thank you all for coming.